Luego, esto sí, dale ahí. Vale, muchas gracias. Bueno, pues vamos a pasar al profesor Radke y él nos va a hablar un poco de la visión más ya de la teoría a la práctica. Y vamos a ver con Ticagrelor, a ver cuál es su experiencia y su uso en el día a día.
Gracias. Ladies and gentlemen, first of all, I would like to thank the organizers to invite me here to this beautiful town of Sevilla. I'm unhappy not to be able to stay longer, but I could follow the talk of the gentleman before me due to the very good translation service. So I have the same conflict of interest as the previous speaker, but I also have a language conflict. Perdón, no habla español. So please let me talk in English. Thank you. So is it worthwhile talking about acute coronary syndromes at all? Sorry for the translation. Oh. So vielen Dank. So shall I talk in English or in German? So there is a translator. She's perfect. But I would like to raise your hand who wants me to speak in English. So thank you very much. Vielen Dank für Ihre hervorragenden Kenntnisse. So that was a major decision. So is it worthwhile talking about acute coronary syndromes and mortality differences? Because over the last 50 years, treatment of ACS has improved dramatically. And this is shown in this slide. So over the last 50 years, 30-day mortality of patients with acute myocardial infarction could be decreased from 50% down to 10%. And diabetes was an issue in the previous talk, so diabetic patients always have a worse prognosis as compared to non-diabetic patients. So although we've improved treatment a lot over the last 50 years, diabetics always do worse, so they deserve special attention by us. And still 10% 30-day mortality is a lot, so there's also room for improvement, and it's even worse after discharge, so mortality rates 1 to 4 years after an index event as an acute coronary syndrome are very high, so secondary prevention is also incredibly important. So I was asked to specifically address now one of the drugs that have been discussed previously, that is Ticagrelor, and specifically address clinically relevant issues, so issues we learned over the last nearly 2 years when Ticagrelor was introduced in Germany beginning of last year. And there's a lot to say about it, but I would like to focus on 3 areas I personally found very interesting. That is first, the indication and the question how we translate a guideline into clinical practice. And I will tell you that it is a long journey from a guideline to our patients. Secondly, I would like to address 3 specific patient subsets that we were a little bit afraid that were those patients with COPD or asthma, those with bradycardia, because that was highlighted as well, and those patients who do have atrial fibrillation and need so-called triple therapy. Whether this is an option in Ticagrelor or not, I will address thereafter. And at the end, I would like to leave you with a few slides I brought together, as we do have I would say, challenges in keeping our patients on the 12 months recommended dual antiplatelet therapy. And I would just like to give you a few ideas we've developed over the time how to accomplish this. So to start with a patient example, so this is a rather unspectacular 12-lead ECG in a 74-year-old lady who came to our emergency department on Sunday, 9 p.m. She has had symptoms for the last 2 days, and the symptoms came and went again. Now she does not have any pain for 4 hours, her blood pressure is stable, and the high sensitive troponin was 250 nanograms per liter. The gray score was 163 points. So in fact, she is at high risk, and Sunday 9 o'clock in Germany is a very popular time for a very special TV series. So most interventional cardiologists do not like to leave their home Sunday at 9 p.m. And in this specific case, there's no ST elevation. The patient is pain-free. One does not have to rush into the cath lab. However, we have to start drugs. And in the good old days, that was pretty easy because there was aspirin, 500 milligrams intravenously, or in the US, you have to chew aspirin as it's not on label. And we loaded patients with clopidogrel, either 300 milligrams, and then years later we started to load them with 8 tablets, which is equivalent to 600 milligrams. And thereafter we continued 75 milligrams per day. So these patients were preloaded and could wait, and this lady was then brought into the cath lab 8 o'clock Monday morning. And then please let me repeat probably 3 slides you may not have seen in the previous talk, but you may have seen dozens of times before. So then 2 new drugs were introduced into clinical practice by 2 major trials that showed superiority above clopidogrel. That was prasugrel in the TIMI-38 trial. And one aspect that has not been addressed by my previous speaker, I would like just to show you. In TIMI-38, it was pretty apparent that the major advantage for those patients receiving prasugrel occurred within the first 30 days. After 30 days, there was also a slight gradient of benefit, but the majority of the advantage of prasugrel became apparent in the first 30-day regarding the reduction in ischemic endpoints. It was a little bit different as compared to the key safety endpoint. So over time, there were more bleedings in the prasugrel group as compared to the clopidogrel group. You've also seen the Ticagrelor data, I'm sure, and the only thing I would like to stress here is that the effect, please just focus on the left-hand side, the effect of Ticagrelor increased in size over time. So this is a difference as compared to prasugrel, and also there was no significantly difference in the bleeding events, and there was also mortality reduction in those patients receiving Ticagrelor of a relative 22% all-cause mortality reduction, which has not been seen by the prasugrel. So, and as a result, the guidelines have been put into words as depicted by the previous speaker, and I would just like to show this slide because this was not published when we started using Ticagrelor in Germany. This was published last year, in the course of last year, by Christian Hamm and a huge group of European cardiologists. And one thing which was new, that as compared to previous guidelines, all the drugs received a class 1 indication, which means this is the gold standard, if you like. And the difference was that there was more text in the guideline. And if we go through the 3 drugs we had to choose or had the opportunity to choose in our hospitals, starting with Ticagrelor, it read as if, and that is the result of the study design, that it is recommended for all patients, regardless of the treatment strategy. So that means whether we go into the cath lab or we do not go into the cath lab, whether we do a cath and then proceed to PCI or don't proceed to PCI. So in Germany, roughly 70 to 80% with acute coronary syndromes do undergo coronary angiography. But only 70% of those patients who do undergo coronary angiography also proceed to PCI. So 50% of all patients with, and I'm talking about the non-ST ACS patients. So roughly 50 to 55% of those patients with non-ST ACS finally end up with a PCI. And that is in contrast to prasugrel, which is recommended for those patients who did not receive prior loading. As a result of the study design of Triton 38, it was not allowed to pre-treat patients with clopidogrel, and in whom coronary anatomy is known and who then finally undergo PCI. So that was a major difference resulting from the study design, which we had to take in consideration when trying to figure out what drugs of the 3 drugs we would preferentially use in our hospital. So clopidogrel is recommended for patients who cannot receive ticagrelor and prasugrel. And I don't want to go through the STEMI recommendations because it has been elegantly done. However, it is a similar situation where all drugs did receive the label of a gold standard with a class 1 indication. However, it needed a little bit of more reading, as in previous guidelines probably, in the tables, because there was also another perception that prior stroke or TIA were exclusion criteria for patients that could receive prasugrel, and there was this age limit of 75 years that had been depicted prior before. So what happened in the beginning of last year in our hospitals was that there was a lot of confusion among all of us, not only the junior doctors, because we had 3 drugs available. And to start with the loading procedure, we did not only have to understand the contraindications and the limits regarding stroke, TIA, the age limits, and the weight limit of 60 kilogram, and the preloading, and the invasive thing. We also had to learn about loading doses. And it starts, let's say, with ticagrelor, where you load with 2 pills. You can load with 3 pills if you have patients who do receive prasugrel in a weighted below 60 or age above 75, although there is no clinical data supporting it, but pharmacological data is there out. Then 4 pills would be sensible in those patients who would receive clopidogrel with 300 milligrams, 6 pills if you take the usual prasugrel loading, or 8 pills if you take the clopidogrel. So this was a lot of confusion, this 2, 3, 4, 6, or 8 pill loading. So, and we are sensibly looking in issues of risk management, and what became apparent that so we have registries where people can tell whenever something went wrong. So like in the flying businesses, and we had a lot of misloadings in these times. So what we then did was to understand the timing and the indication differences, and to kind of translate the guidelines into a real world scenario where we understood that only clopidogrel and ticagrelor do have the indication for the whole spectrum of patients with acute coronary syndrome, whether or not they are preloaded with clopidogrel, whether or not they undergo reperfusion therapy here in STEMI, which is most cases the case, or whether they go invasive diagnostics and treatment. And for reasons of study design, prasugrel prasugrel received the indication for reperfusion therapy in STEMI. It's a good indication though, and for those patients who do undergo a PCI in non-ST ACS, non-ST elevation ACS patients. So this was the landmark, if you will, for our decision how to use ticagrelor. And I can tell you, it is a very long journey from a guideline to a patient. And what we did was that we all know about the guidelines, and we all know about our patients, but there's a lot to do to bring guidelines into reality. And we decided, we founded a task force of pathways in Germany, and we understood that process modeling, flowcharts, pathways, and standards in hospitals are very important to bring those guidelines into clinical practice. And I don't want to bother you and bore you with the complexity of how decisions are made in hospitals. But I want to show you on the right-hand side that we started to define standards for our own hospitals to use clopidogrel and ticagrelor in specific patient scenarios, and how many pills how many loading pills have to be given and what the maintenance doses were. So regarding subsets, dyspnea clearly was an issue in the ticagrelor trials. That has been shown by Rob Story. It has also be shown that the lung function parameters of obstruction and restriction have not changed. So this is another phenomenon of fibers, so this sensation issue rather than a change in lung function parameters. Interestingly enough, we don't see a lot of patients with dyspnea after ticagrelor intake, but I have heard reports from other colleagues in other areas who have more patients who are about to stop ticagrelor due to dyspnea attacks. It may be the case that we don't really look for patients with COPD grade 3 or 4 who are on steroids and do not treat them deliberately. So this may be a patient cohort we prefer clopidogrel when they have an advanced COPD. We are more relaxed with bradycardia. I mean, you may have seen the data in Plato, as it was a double-blind randomized controlled trial. There were no more pacemaker implants in the ticagrelor arm, and these were not AV conduction disturbances. So in those patients, for example, with inferior myocardial infarction, we see on the ICU, when they do develop AV block, we probably then do not give ticagrelor rather than clopidogrel, but these are rather rare cases. Of course, we have to know and respect contraindications, warnings, and precautions. One issue or two things I would like to stress. One thing is the maintenance dose of aspirin. You may have heard that there is an interaction between the aspirin doses in the US. The US prefer to give 500 milligrams per day, whereas in Europe we have doses of 75 to 125 or 100 milligrams, probably in Spain as well. And the gradient of benefit is higher in patients who receive lower doses of aspirin. This may be a result of the COX-1 and 2 interactions of aspirin. So lower aspirin doses are recommended. And secondly, ticagrelor should not be given with simvastatin more than 40 milligrams. So this is something we all have to bear in mind, but I'm sure you are aware of it, and we did not challenge this recommendation, of course. There's one patient cohort we clearly do not give ticagrelor. That these are those patients who do have a good indication for oral anticoagulation, let's say patients with prosthetic heart valves, or those with atrial fibrillation and a high CHA2DS2-VASc score of 3 or 4. Then we stay with clopidogrel in combination with Coumadin or warfarin plus aspirin. So compliance may be an issue you are interested in. Clearly in Germany it's an issue. We know, as I said before, that event rates are also high after patients do leave the hospitals. Therefore, secondary prevention is extremely important. For example, as has been shown in the Great GRACE registry, it's quite compelling to see here that patients that present with ST depression have a worse outcome over the first half year than those patients with ST elevation. But we all know that the STEMI patients are younger, who have better LV function, less involved coronary arteries, and less often diabetes than those patients with non-ST elevation MIs. So secondary prevention is extremely important, and with ticagrelor, as has been shown previously, the gradient of benefit increases with time. So if we start with ticagrelor, we want to make sure that patients take it for 12 months. And the chain of survival is very well organized in the area I come from, but I'm very sure that this is also the case in Sevilla, Madrid, and pretty much everywhere in Spain. So the chain of survival from symptom onset to the defined therapy is very good. And we have strict timelines, tough timelines, I have to say, 90 minutes from first medical contact to cath, is even, but the chain of information for the patient also increases with time and is highest in rehab. In Germany, there's a lot of rehabilitation going on, and patients are educated very well. But once they're home, they laugh about their pills and drink their beer. So this is important for us to understand, that chain of information decreases over time. So does the compliance of our patients. That has been shown in numerous trials. That, for example, in this study with over 1,500 patients receiving drug-eluting stents, 10% patients do stop the dual antiplatelet therapy after 6 months, and only 85% or 84% do take it for 12 months. In reality, in Germany, the data is even worse than what we see here. And we know that premature discontinuation increases the risk for stent thrombosis. This is the very first data we've been seen 7 years ago by Iacobu, with an odds ratio of 160 if you stop 3 months or earlier after drug-eluting stent implantation. So we've been thinking about a patient letter with individualized information that is easy to understand, really focuses on the patient's need, clear presentation is made to the specific problems of your patient. So we want to make the patient act, we want to make the patient take responsibility, but I have to tell you that it's so much work for us on the wards that this is a very good idea, I assume, but until now we have not accomplished doing this because our junior doctors on the ward just don't have the time after writing the letter of discharge, also writing patient letter, but we are still working on it. And there are a lot of initiatives in Germany at present going on, for example, from the German Association of Cardiologists in Private Practice, that is the BNK, who give their patient information letters, etc. And the same is true for an initiative by AstraZeneca, which is not focusing on Ticagrelor. It's a very general information package, which holds true for those patients who do receive other antiplatelet drugs as well. And there's a coaching process involved and information packages for our patients, which is quite interesting. So to summarize, what have we learned from over the last nearly 2 years regarding the transition from study data into guidelines, into clinical practice? So there is also what I would say theory, and that was the topic of the talk I had to cover. We've learned a lot about the pharmacology and the studies and the data of different antiplatelet drugs, and as you said before, Prasugrel and Ticagrelor are Formula 1 cars, and they are better than clopidogrel in nearly every context. They act faster, they do suppress platelet activation to a higher extent, and they are more predictable because the genetic interaction is different. However, the studies were different, and as a result of differences in TIMI38 and the Plato trial, there are different indications for Ticagrelor and Prasugrel. So I would agree that these are two Formula 1 cars, but they are running in different circuits. So we've decided to, in our hospital, and that is not representative of whole Germany, so I can't speak for Germany, I can speak for our hospital. So we decided also to reduce errors that are made when it comes to dosing, to use both clopidogrel and Ticagrelor. I told you that there are good reasons to use clopidogrel, still clopidogrel, but there are a lot of patients who benefit when receiving Ticagrelor. The data is very specific, but we and everybody else does face a lot of problems when we want to serve the individual patient. So individualization is something we really want to take advantage for our patients. But on the other hand, when we try to organize a hospital, we have to standardize a lot. And the balance between standardization and individualization in our practice is one of the largest challenges I think we have to face so far. Thank you very much for your attention.